Okay, we've got a good number of people here. Welcome to the CKD E-Learning session that we're hosting today. Adeera Levin is the speaker. Questions are to be kept to the end if possible, and please use the Q&A feature at the bottom of your screen to send in your questions. They'll be reserved for the last 10 to 15 minutes of the session. And I will pass it over to you, Adeera.
Great, thank you very much, Sidonie, and thank you to all of you for making time in the middle of the day or whatever it is that you choose to watch this. And I am privileged to be speaking to you from the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples, and all of you are wherever you are in this province or country. And so my job in the next 40 minutes or so is to go through how we really change practice in the face of chronic kidney disease care. These are my disclosures, which I prefer to think of as perspectives, because I am a clinician, administrator, and a researcher, and I have grant funding from a number of sources, including both nonprofit organizations as well as industry support. And I've had the privilege of being on a number of steering committees and participating in SGLT-2 inhibitor trials, which is the focus of what most of today is about. So the learning objectives are that we will improve our understanding together of the mechanism of action of SGLT2 in protecting kidneys and hearts and vascular systems. We'll review some clinical trial data in the different chronic kidney disease populations that supports the use of SGLT2 inhibitors, and also be clear about what the side effects are and the caveats for the use of SGLT2 in clinical practice. But how you translate that improved understanding to clinical practice is really important. So ideally, you as clinicians will be able to identify people who are most likely to benefit from these new class of agents, help you to start them where and when appropriate, optimize therapy for chronic kidney disease by incorporating this new class of drugs with other kidney protective agents, and ideally we'll have time for an open discussion with all of you. I wanted to give you a context that really, if you look at the productive life years lost due to premature death or disability in chronic kidney disease, is irrespective of whether or not you look at 1990 or more currently 2017, there's a huge amount of death and disability attributable to kidney disease, irrespective of the cause. And here in this slide, you'll see that there's type 1 and type 2 diabetes, glomerulonephritis, hypertension, and other unspecified. All of these are major drivers of disability. Sadly, there are low rates of awareness and detection in the current era, despite all of our discussions. This is a paper from Kathy Tuttle's group that looks at two large US healthcare systems with about 2.6 million people, half the number of people that are in British Columbia, in which only 15% of people with diabetes had albumin measured, and those with who had diabetes and no CKD, only had 5% of people had albumin measured. So I think it's a testimony to not understanding the prognostic implications perhaps of albuminuria. And in that same population, if you had diabetes, kidney disease, and hypertension, your use of best therapies of ACEs and ARBs was 25%. The use of SGLT2 inhibitors was almost negligible. This is over this time periods. And the use of things that might exacerbate kidney disease, PPIs and non-steroidal anti-inflammatories, was high in this group. So we're not using the good drugs, and we might be overusing the bad drugs in people who are at risk for progression of kidney disease. And this is just one more reminder about the fact that age standardized disability adjusted life years is about 63% of people in low and low middle income countries, and probably not much different in high income countries, but is really important that we think about death due to chronic kidney disease and disability adjusted life years of people with kidney disease, as these are really growing problems around the world. And in Canada, 1 in 10 has chronic kidney disease. That's about 4 million people. Kidney failure has grown by 35%, and diabetes, which I'm going to focus on, but is not the only cause of kidney disease, is the leading cause in about 40%. I think, to be sobering, about half the people who are starting dialysis or transplantation are under the age of 65, and about 50,000 people are being treated for kidney failure in the current moment. And I think these are just sobering things to give us, I hope, a sense of urgency of why we're having this talk. And the economic impact of kidney disease is also profound. Dialysis costs about $100,000 a patient year. The out-of-pocket costs associated with dialysis can amount to about 12.5% of someone's income. And the cost to the Canadian healthcare system are about $50 billion per year. And as I've stated before, CKD patients are less likely to be employed, which gives them a productivity loss. And one of my colleagues, Dr. Mans and others, looked at the CPP and private insurance costs that amount to almost $1 billion per year for this group of patients. And in Canada, we have a growing rate of people starting dialysis due to diabetes. And so this is really a moral imperative. And until recently, the standard of care for people with diabetes was based on 3 cornerstone treatments: A1C control, blood pressure control, and RAAS inhibition. But control of blood sugar has limitations with respect to some of the patient outcomes. And I'm not showing you all of the data, but people who got intensive glycemic control didn't actually have protection against cardiovascular events in all the trials done in the last decades. Intensive treatment of A1C with targets might increase the risk of cardiovascular events and mortality if you don't actually achieve those targets. And while there are reduction in kidney events associated with A1C control, they're statistically and clinically significant. There's still a fair amount of a residual risk that remains, and I'll show you this more graphically in a moment. When it comes to blood pressure control, studies in the 90s showed that if you improve blood pressure control, you slow the progression of kidney disease or eGFR decline. And you can see in this relatively old slide from George Bracker's untreated versus controlled hypertension. Untreated is about 10 to 12 mils per minute per year loss of kidney function, and with control that reduces to 5 or 6, and this is again done in the 90s. In the ADVANCE trial, there was a relationship between blood pressure and risk of kidney events, regardless of the medication. And this is similar to another trial that I'll show you in a moment, the ID&T trial. But basically, the lower your blood pressure, the lower your annual event rate of kidney disease or kidney failure. But there are limitations also to impact blood pressure control. So it might interest you to know that 2/3 of Canadians with diabetes have hypertension, but almost half of those are not controlled. That most studies demonstrate benefits with blood pressure control on albuminuria, not on kidney function or the incidence of kidney failure. So again, there's a substantial amount of residual risk. And RAAS inhibition, which is our third cornerstone, has been shown very nicely to reduce progression to overt nephropathy. This is a study looking at irbesartan at 2 different doses and very much shows the incidence of diabetic nephropathy markedly reduced at different doses of ARB. However, there's a considerable amount of residual risk that still exists with the current standards of care. And in this orange is basically it's hot in that our risk reduction is only 20% if you look at ID&T or Renal, which means that a fair amount of risk still exists in this patient population. The other thing that's interesting is in the diabetic kidney disease studies, the RAAS inhibition did not provide protection against cardiovascular events. They did not change mortality. And most of the risk reduction in those trials, ID&T and Renal, were with respect to delaying progression of kidney disease or going on to dialysis. There's still an ongoing risk for kidney and cardiovascular events. So yes, A1C, yes, blood pressure, and yes, RAAS inhibition as cornerstones. They're all critical components, but we really need to improve the lives of our patients by building further on this rock foundation, if you will. So I want to talk about how we changed clinical practice and give you a little background to about the SGLT-2 inhibitor story, the studies, the design, the results, why it's impactful, and some of the limitations, because nothing is perfect. I just want to make sure we're all on the same page. This is a new class of drugs, really around since about 2015 in the common world. They're the gliflozins, they're Cana, DAPA, and EMPA. They have slightly different properties, but that's not the purpose of this talk. You might be interested to know that the florazin is a natural compound that was found in the bark of an apple tree by French chemists back in the 1800s and was used to study diabetes and kidney function for decades because it induces glycosuria, thirst, and weight loss in dogs. And so that's how it came to be. And it was first described, in order for it to work, there had to be a co-transporter mechanism in the kidney. And this was first described by Robert Crane in 1960, literally on the napkin, which is shown here, where he hypothesized what the mechanism should be, which was then actually found to be so. And again, not for this audience or for most audiences, but interesting to have those stories of how these things came to be. So since 2015, there have been key SGLT-2 inhibitor trials, cardiovascular outcome trials, kidney outcome trials, and heart failure trials, respectively in blue, orange, or yellow, and black. And I'm going to tell you a little bit about the results of those, but they start in 2015, and we had an unexpected result in EMPA-REG outcome, followed by a general cardiovascular outcome trial, CANVAS and DECLARE. Subsequently, the kidney trials, which I'm going to spend more time on, CREDENCE and DAPA. And I think they tell a really great story about where we have come from and where we're going. Importantly, if you look at all the SGLT-2 inhibitor trials, they have very large numbers of people in them, 7,000, 10,000, 17,000, and the kidney studies combined almost 8,000 people. Many of these people had some degree of kidney dysfunction, even in the cardiovascular trials. They're around 60 years old. The important thing is very few of them, other than the kidney trials, CREDENCE and DAPA, had enough patients with GFRs of under 60 or with proteinuria for us to be able to say anything about them, and hence the reason why these two were constructed and designed. But as general practitioners and general internists, I would put to you that certainly the totality of the data suggests a very large group of people who have been studied with respect to these medications, and we can come back to that. Importantly, I'll just remind you that all of the studies had baseline use of RAAS blockade, that cornerstone of therapy, and in the kidney trials, between 97 and 99% of all people were on RAAS blockade. So the baseline risk, if you remember your heat map, stages of kidney disease by amounts of proteinuria, and you'll recall that the CREDENCE study is actually looking at people who had GFRs between 30 and 90, and urine ACRs that were high. The DAPA had lower GFR and slightly lower urine ACR, and EMPA is not yet finished, but has even lower GFR and only urine ACR requirement for those with higher levels of GFR. So soon we'll be able to have the entire spectrum of different effects in these different populations. So importantly, I'll just skip over. So CREDENCE. So this is one of the key and the first kidney trial. So you had to be over 30, have a GFR that was between 30 and 90, and a urine ACR in our Canadian units of over 33 and less than 500. Confirmed type 2 diabetes, and you had to use an ACE or an ARB, a median A1C that looks just like what you and I see in the office, and a mean blood pressure of 140. On a base of that, the kidney outcomes were reduced by 30%, 3-point major adverse clinical events by 20, cardiovascular health and death, and heart failure for hospitalized heart failure of 31%. And all-cause mortality was not statistically significant, but reduced by 17%. And it's important that the kidney outcomes included all the different ways that you could get to kidney disease, including doubling of creatinine, dying of a kidney or renal death, and going on to dialysis or transplantation. Similarly, in DAPA CKD, you now have a younger cohort, including those over 18, a lower GFR, a slightly lower entry-level urine ACR. Not everybody had diabetes, and ACE or ARB use was also very high with really good blood pressure control. And in this study, importantly, renal events were reduced by 40%, 3-point MACE was not statistically significant, but cardiovascular death and hospitalized heart failure importantly reduced at 30%, as was all-cause mortality. So 2 studies with similar but not identical outcomes and populations, but all with a kidney focus and both highly positive. The EMPA kidney study is not yet finished, but is including people who are over 80 with or without diabetes again, who have lower GFRs and protein or no protein, and has similar composite outcomes. So stay tuned. The results of that will be available in a little while. The SCORED trial, which was published in the New England Journal, looks at people with and without major cardiovascular risk factors, as you can see there, also with GFRs between 25 and 60 and urine ACRs that are quite low at this point, who also have diabetes, are also on an ACE and ARB with reasonable sugar and blood pressure control, the cornerstones, and showed, again, importantly, the primary outcome, which was a composite, the kidney composite, and 3-point MACE, all being highly significant. Importantly, all-cause mortality was not, but this trial was stopped early because of a withdrawal of funding, but not for any other reason that we're aware of. So if you look at the kidney benefits of SGLT-2 inhibitors, I think important for this audience, these are independent of hemoglobin A1C. So in credence, whatever your baseline A1C was, and in DAPA, whether you did or you did not have diabetes, all of the results favor the SGLT2 inhibitor. So that's quite important. They're safe. The meta-analysis of all the kidney AEs in patients with low GFRs across 5 trials of CANA, DAPA, or EMPA all demonstrate no major impact and no signal at all for a problem with the SGLT2s. And if you look at acute kidney injury, something that a lot of people are concerned about or were concerned about at the beginning of using these, again, this looks like a favorable effect of SGLT2 inhibitors on acute kidney injury, which I think is really interesting, and we can talk about that as we want. And if you look at other safety signals, not just acute kidney injury or hyperkalemia or things like that, there are meta-analyses of up to 10 clinical trials looking at low blood sugars, fractures, amputation, UTIs, genital infections, low volume of diabetic ketoacidosis. And the only 2 that are truly important, and we can talk a bit more about this, will be mycotic genital infections in DKA, and we'll talk about relative and absolute risks when we get there. To summarize where we got to at this point is that the SGLT2 inhibitors have demonstrated an amazing ability to slow GFR. I didn't show you the Kaplan-Meier plots yet, but I will in a moment, and reduce the hard kidney outcomes because patients actually care about whether they end up on dialysis or not. There's consistent benefits for hospitalization for heart failure, which is really important also for the healthcare system. And they seem to provide benefit on 3-point MACE and overall survival in patients with type 2 diabetes and kidney disease, and even in those who have kidney disease without type 2. And so these cardiorenal benefits are provided across a spectrum of kidney function, which I think is very exciting. So I want to go back to the DAPA study because importantly, this shows that even in those with and without diabetes, there is an impressive impact on all of the outcomes. And the number needed to treat to actually reduce impact progression of kidney disease, kidney failure, or kidney or cardiovascular death is 19, which I think needs to really be highlighted when we're thinking about treating populations of people. And all of these hazard ratios are highly significant and positive. And again, just to highlight that this effect of the Flozin family, and in DAPA in particular, because that's the one that's been studied most, is consistent irrespective of the diabetic status. And so this is just looking at all the different outcomes in DAPA and showing you that with or without diabetes, the events per 100 patient years are the same across everything, whether that's the primary outcome, the kidney-specific composite outcome, cardiovascular death or hospitalization for heart failure, or all-cause mortality. And it's also irrespective of the reason for your kidney disease. So as a nephrologist, certainly we are seeing people with diabetes, not predominantly, but about half of the people, and the rest of the individuals have other kinds of kidney diseases. So for those of you in general practice and others who have people with impaired kidney function and no diabetes, I think this is a very good signal that this also is important for non-diabetic kidney disease. The safety results in DAPA, which I happen to have in detail, are again very important to note that the actual number of people with any events is quite low and not significantly different in between placebo and the active drug. And we'll talk some more about this in a moment. Again, on kidney failure, if I put all of the studies together, there's overwhelming benefit of these SGLT-2 inhibitors. And this is just putting all of those studies together, diabetes and not, in case I haven't made that point. And I want to reiterate that this is because the mechanism of action, which I'll get to in a moment, is not dependent on lowering of blood sugar. One of the big questions we get asked a lot is whether or not the SGLT2 inhibitors work at lower GFR levels, and the answer to that is yes. In the DAPA study, the risk of primary outcomes, regardless of CKD stage 2, 3, or 4, was evident across all the outcomes of interest, be that the primary outcome or the different components. And when you look at the people who had a stage 4 or stage 3, you get a very similar dip in GFR and then a plateauing over time. And these are the slopes that when we saw the first study of EMPA-REG got us so excited, but interestingly seems to have persisted no matter how bad your kidney function is. There is this dip and then a plateauing which occurs, and then placebo group always has a ongoing relentless decline in kidney function. And this is looking at canagliflozin specifically by screening GFRs, and you again see exactly the same difference. And I think that's important to notice that the lines cross, the benefit appears early. At 14 months of the higher GFR, 11 months at 45 to 60, and a lower GFR at about 8 months. And I think this is also important to note when you're trying to reassure patients and look for when things should change. And if you look at just the people who had a baseline GFR of less than 30, even though canagliflozin entry criteria was greater than 30, there were a small group of people who entered who had a lower than that GFR, and you'll see again an improvement in the canagliflozin group versus the placebo group over time, even at the very lowest GFRs. So let me go back to cardiovascular disease, because the limitations of RAAS inhibition, especially in people with type 2 diabetes, is really not there. And if you include the IDNT, Renal, and advanced studies, you'll note that ACE and ARB do not necessarily lead to improved cardiovascular mortality in those with diabetes and advanced chronic kidney disease, if you look at IDNT, Renal, and advanced. But there are these benefits of SGLT2 in kidney disease, as shown in CREDENCE and DAPA. And I've shown you these slides before, but again, importantly, quite consistent across the two agents in slightly different, but some overlapping populations. And if you look at those benefits across all kidney function, you'll see again that favoring the SGLT2 inhibitors across the spectrum of GFR and urine ACR is really quite impressive, and so gives us, this is with CANA alone, because it's a huge analysis with CANVAS and CREDENCE, but has actually been replicated in other studies as well. Recently, there's been a study of SGLT2 inhibition in decompensated heart failure, the SOLOIST study, and again, that showed an improvement in heart failure populations in those taking ACEs and ARBs adding this agent. So much so that the abundance of evidence has led to the Canadian Heart Failure Society practical guide to when you start SGLT2 inhibition in patients with type 2 diabetes, or those with CKD, or those with HFrEF. And the important thing to note is that they've actually have some clear initiations of outpatient SGLT2 inhibitors with a little bit of special considerations about monitoring, which I'll get to in a moment, and some follow-up routines. So we can talk about this in more detail and get to the question and answer, hopefully. So of course, it can't all be this good, right? So it's too good to be true. And I thought, you know, whenever you see great results and for a class of drugs so consistently across so many different populations, you ask yourself, but certainly there's a problem with these side effects. And there's certainly been a lot of noise about things like fractures. When you put all of the studies together, I want to draw your attention to the fact that there is no difference in any other than canvas for fractures. And that was likely due to some statistical error, but you'll see that the relative rates of any of these things is still very low in all of these groups of people. So 1% of all people in credence had a fracture, and 1.18 and 1.21% of all patients in placebo. So the absolute rates are low, and they are not different in the majority of studies. And where there's been a lot of discussion around a statistical anomaly. When you look at amputations, it's the same. Again, canvas was the only one that's ever been shown. And this again was thought to be due to a statistical issue because the people in canvas are weller than the people in credence who should have amputations. And here the amputation rate is the same in both groups. Volume depletion. Again, the hazard ratio crosses 1. What I really want you to see is that it's 2% of 4,000 or 2% of 2,000 people. These are not large numbers of events in any rate, and again, easily mitigated by changes in diuretics, etc. And urinary tract infections are often a limiting thing. Lots of people don't want to start SGLT2s because of this. And again, I'll note to you that UTIs are not any more common in placebo versus SGLT2 inhibitor trials. And that's important to remember, and that the rates are still very low and just our baseline population rates. The big one that does actually happen more often is genital mycotic infections. But again, I'll show you that whilst they are much more common if you're on SGLT2, the base rate is still very low. And again, that would reflect your practice, I would think, because you don't see lots of mycotic genital infections, but you do see some. So that does increase that relative risk of having it, but the absolute risk in a whole population is still low. I think that's really important. And this is just showing you it's more common in women than men overall, but the total number is 91. This is in the credence study. And so you'll see there that the drug was discontinued in about 90% of people, but many had a subsequent genital mycotic infection, and you'll see the rates are the same. So again, my point is, yes, they increase the relative risk, but the absolute risk is already very low, and it's increased proportionally. So let me go back to what the facts are. And hopefully, because you're at your computer screen, you can see this. SGLT2 inhibitors do improve outcomes in people with diabetes and patients with CKD and those with established heart disease and all the various combinations, whether you want to look at kidney outcomes, cardiovascular outcomes, or heart failure. There are multiple randomized controlled trials that are concordant with over 20,000 patients at my last count. There's biological plausibility and a number of mechanisms by which this may occur, which I'll show you in a moment. We now have, with all of those clinical trials, identifiable patient profiles. There doesn't seem to be an impact on glycemic control at lower levels of GFR, and all of the effects are independent of the lowering of blood sugar. There is no increase in incidence of acute kidney injury, and the effects seem to be across any category of GFR and urine ACR in all the population studied to date. They're irrespective of the use of ACEs and ARBs, and I think that's important. And whilst that is one of the cornerstones of therapy, not everyone can be on it or tolerate it. And I think what I didn't say at the beginning is that all of these studies used fixed doses of SGLT2 inhibitors without any targets. And I think I'd like to come back to that. The KDIGO 2020 guidelines for the diabetes management in chronic kidney disease suggest that all patients with type 2 diabetes and CKD should receive the base therapies of glycemic control, blood pressure, lipid management, and lifestyle characteristic counseling, and that most should also receive an ACE or an ARB and SGLT2 inhibitors based on the current data, and that in some patients, antiplatelet agents are also required. But this is the totality of management of CKD, with now SGLT2s being on par with RAAS inhibition. Canada, the diabetes group has actually come up with the fact that SGLT2s or GLP-1 receptor agonists should be thought of to reduce MACE, hospitalized heart failure, and progression of kidney disease. And so that's the first time that that's come up in the Canadian guidelines, which is a strong recommendation. So let me contextualize all of this data into clinical practice. And I'll tell you what I used to do or what I did before in the care of kidney patients. Of course, I paid attention to all the things you see listed here: blood pressure control, glycemic control, RAS blockade to lower protein in the urine, key interdisciplinary teamwork with the nurse, dietitian, social worker, and pharmacist, and regular monitoring of the blood work and the urine ACR, and then regular intervals to assess, educate patients, navigate the system, and have ongoing surveillance. And I did a lot of fiddling with blood pressure and which and what and how, and a lot of discussions around AKI management, and really making sure that people understood sick day rules and all the other things that you see listed here on this slide: protein intake, salt intake. I focused sometimes on hyperuricemia, lifestyle, all those things. And where that got most of us is that whilst within diabetes especially, I could improve a lot of these things, I wasn't able to change at all the incidence of kidney failure. And so if you think now about all the studies that I showed you that are fixed dose with no targets on top of best care with international populations, you have Credence, which is diabetic kidney disease. You have DAPA, which includes diabetes and non-diabetes disease. And you have EMPA, which is coming. And these are important because together they tell us a lot about what we can do next. So in general, all the diamonds here are on the left-hand side of the house, which actually tells you that these things work for just about everything. And I want to show you what this means. If you're in the Credence study and your placebo change in kidney function was around 5 mils per minute per year, because they had good blood pressure control and everything else, and your danger zone of kidney function is to get to around 10 mils per minute. If you were in the Credence study, the average patient who was 63 when they entered had a slowing of their rate to about 1.85 per year, which means that they gained about 13 years before their GFR got very low. And which means that they don't reach that 10 until they're about 86. But more importantly, if you think about the annual cost of dialysis, whether that's peritoneal dialysis at about $40,000 a year, in-center hemo, which at base is 64, but up to 100,000, there's a huge ability to actually cost save for 13 years of about $500,000 for PD and almost $1 million for in-center hemo if you just do this back of the envelope kind of modeling calculation. So there's so many ways that SGLT2 inhibitors improve outcomes. They reduce albuminuria, hyperfiltration. In some people, they lower the glucose, but not in those with lower GFRs. They make sure that you are euvolemic by having a diuretic effect. They have some anti-inflammatory effects. They reduce weight by about 2 to 3 kilos, so can also help to address some obesity issues. They attenuate GFR decline. They reduce ischemia within the renal parenchyma and probably the myocardium. They improve blood pressure control. They're probably antifibrotic as well. And so if you think of those mechanisms and how, if you inhibit the SGLT2 pathway, you get an improvement in your effective circulating fluid volume, probably alter metabolism, and also get a sodium diuresis. These together result in a reduction in arrhythmias, a change in cardiac output with a delta preload, afterload, and improvement in cardiac efficiency, a change in arterial wall integrity, GFR and albuminuria. And it's probably through that interaction that we are improving cardiovascular and kidney outcomes, so that all of the studies that I showed you actually now make sense if you think about how it is that this medication works. So I've told you about the studies, how they were designed, what the results and conclusions are, and I think why it's impactful. And so I hope that this translates to improving understanding, so that you can translate this into clinical practice, figure out who in your practice is most likely to benefit from an SGLT2 inhibitor. Hopefully it's easier for you to start people on these medications and then optimize therapy for chronic kidney disease. And with that, what I'd like to do is actually stop, and maybe I'll stop sharing my screen and open it up for discussion and questions. And I thank you all very much for your attention, and for BC Renal for setting up this, this talk. So I'll stop there. And I see that we have about 30 people on the line, so I'm happy to answer any questions as they arise. My first question is, did I go too fast? So there's a Q&A. How do we minimize the risk of DKA in the context of surgery? What's the cause? So usually the problem, so it's a great question, Casey. So the diabetic ketoacidosis does occur. It occurs usually during an intercurrent event, and usually because people stopped their insulin. So number one, and I should have made more of a point of it, but the SGLT2 inhibitors, you have to have sick day or intercurrent event rules. So usually we stop them 2 days before and don't restart them for at least 2 days after an intercurrent severe illness where you can't eat and drink properly. This is the SGLT2s, or surgery. One should never stop insulin, on the other hand. And so everybody who's had a DKA episode has actually had their insulin stopped or severely reduced. And so that's the way that one would minimize the risk of DKA. Again, the absolute number of patients who get DKA is still very, very small, but it's a great question. The next question is, at what GFR level do you discontinue the SGLT2 inhibitors? And the answer is none of the studies discontinued them. They kept them on SGLT2 inhibition until they started dialysis or got a transplant. And in some patients in DAPA, they were continued even when they were on dialysis. So I don't stop them, but there are these sick day rules, like like ACEs and ARBs or intercurrent event rules, where you do hold them for a period of time if you're concerned. Does any patient group in which you would hesitate to add? I think, like all medications, you know, if you don't need them, you shouldn't start them. People have talked about age restrictions, like, do you really need older people to have delay of progression of kidney disease if they're going to outlive it? Well, that's why I spent so much time also highlighting the cardiovascular benefits. I mean, if old people don't have to go into hospital for heart failure or cardiovascular events, that's also a benefit. So I'm not sure that there's a patient group in which I would hesitate to add. I mean, at the moment, many of you know, and if you're in BC, that we do have an issue with coverage. There are ways around this, but there are ways also to mitigate the total dollar value of these medications. But, you know, we put people on lots of medicines that don't work. So you might want to think about stopping stuff that isn't working and adding this instead if money's an issue. So that was a good, I didn't even see the next question about, is there coverage yet? There's coverage if you fail, if you're a diabetic and you fail 2 oral agents, then you can actually go on to, get it covered. I think we're working on a more comprehensive business case for the ministry and others to make sure that there's a more liberal coverage given the cost savings to the healthcare system. So stay tuned. But as I said, many people can, in fact, afford them if you ask or have a conversation with them. With abdominal surgery, yes, I would. The SGLT2s, they're not emergent. They're not drugs that you need to keep people on while they're having an intercurrent event. So there's no downside to stopping them for a week or 2 weeks, right? So with abdominal surgery or any kind of surgery, our usual paradigm is for a coronary angio or anything like that is 2 days off before and 2 days after, repeat the blood work and then restart. But with more complex events, then there's, again, no urgency to restart. The big thing is you will get the benefit over time. So it's really important to remember to restart them at some point. And then there's another question about what the lowest GFR that I would start these meds. At the moment, the data suggests 25 is the lowest you should start. That's the DAPA study. EMPA will lower that if it's positive to 20. So that would be where you would be certainly on label, if that helps.
Adeera, there's one question in the chat box. I don't know if you noted the side there. How should the initial drop of eGFR be interpreted, managed, monitored?
Great question. So number one, don't measure it. So the best thing to do is it's not like an ACE or an ARB, because remember with the ACEs and ARBs, the reason you're measuring the blood tests, within 7 to 10 days of that is not just the dip in GFR, which you expect, but the potential rise in potassium, which is problematic. With the SGLT2s, you don't see that. So in all of the studies, we didn't actually measure the GFR until 1 month out. So I would just keep them on their regular blood work. I also warn the patients and the doctors that you will see an expected drop, and that does not worry me. It means the drug is working. We're saying a 30% decline in kidney function from baseline is acceptable, and most people have less than that. Does that help, Kate? Other questions or thoughts? I think there might be another question. I'm just scrolling. Yep. Is this the sort of information that you find, someone can write it in the chat, in the graph, find helpful? Are there things that I missed out that you would have liked to hear about or see? Or you can raise your hand and Sidoni will unmute you. I can't see any more questions. Can you, Sidoni?
No, just a comment.
Right. Well, everybody likes 15 minutes back in their life. Feel free to, ask any questions that you may have of your local nephrologist, or you can email BC Renal and they can direct questions to me specifically. There's also the RAAS line, which we certainly field questions about this. And so if you do have any questions, you can, I person the RAAS line, about 50% of the time, and my other colleagues that also do it are also very knowledgeable. So if you do have questions or you're not sure about in whom and when and all that kind of stuff, please let me know, and we can also answer questions that way. I am open to emails with questions, but I prefer they all go through the renal agency as opposed to my personal email, because they'll get lost in translation, Casey. I think the big thing is that this, whilst started as a diabetes drug, You do not get glycemic control at GFRs under about 40. So if you're trying to improve glycemic control with this drug, at lower GFRs, it won't work. It will work for all the other things, but it won't make your sugar better. So I think that's important.
There's one question from Eileen Carolan. She just needs to unmute.
Ooh, there. Does that work?
Yep.
Oh, amazing. I just wanted to be really clear. Do you start the SGLT-2 inhibitors in people who don't have diabetes? Like, are you using it for primary?
Yes. Yes.
Thank you.
Yeah, thank you for that question. Yes, the DAPA CKD was the largest trial done in non-diabetics with SGLT-2 inhibitors. And don't forget that some of the heart failure trials are not only with diabetes, right? So there is an accumulating amount of data in non-diabetics, but the CKD stuff with DAPA is very compelling. Great. Well, listen, thank you all very much for giving up your lunch to talk about SGLT-2 inhibitors and for your thoughtfulness, and hopefully together we change practice. Okay. Thank you. And I believe this will be posted on the BC Renal website and accessible to you that way. Thanks, everybody.